in terms of abnormal tone, um, you're really getting issues with the dorsal reticulospinal and the medial reticulospinal tracts. So these tracts in particular have been shown to be really the main movers that seem to develop tone, and they have a facilitary on the medial side, inhibitory on the dorsal side. And when they're dysregulated, it impacts the stretch reflex circuitry and ultimately leads to abnormal muscle tone. So at the local muscle circuit level, of course, you have the alpha and gamma motor neurons. Um, the alpha motor neurons are the ones that imply the direct movement to the agonist or antagonist muscles. The gamma motor neurons reset the spindle, which is the sensitivity mechanism of the muscle fiber itself to stretch. These are the nuclear bag, nuclear chains, and they give afferent impulses by the 1A and 1B afferents. Go back to inhibit the alpha motor neuron, gives you some presynaptic inhibition. There's also recurrent inhibition by the Renshaw cells, and there's reciprocal antagonism. So if, let's say, the biceps is overactive, the triceps should hopefully come in and antagonize. And that's the normal circuitry. And again, in spasticity, this becomes dysregulated. But you notice in all of these last two slides by Ganguly, we've talked about the neural circuitry. But what haven't we talked about? We haven't talked about this rectangle. This rectangle is the diagram of the muscle. And it turns out in these diagrams, the muscle looks like this passive, unimportant structure in the whole milieu of the spastic circuitry. But it turns out, I think muscle is much more important than we think. So I'm going to be talking more about this in the future slides here. So what happens when spasticity occurs to muscle? Let's see here. So most studies focus on neural dysregulation with the lack of descending inhibition. But the question is the muscle itself affected by upper motor neuron lesions? So Lieber, in 1986, Rick Lieber did a lot of great work on early on an animal model of rats, and he showed that in spinal cord injury model, when he looked at muscle, there was fiber atrophy, there was an increased proportion of connective tissue in muscle, and there was slow to fast muscle fiber conversion. You're seeing that here to the left panel B, the fiber type grouping. So the question is, could muscle histological changes have implications for treating spasticity? Well, this is especially relevant, it turns out, with the extracellular matrix. And again, this is more of Lieber's work. He's done a lot of great seminal papers. We know that in normal, so the far right, the vertical panels here, you see the normal polygonal shape of the muscle fibers that are kind of tightly bounded. You don't see a whole lot of extracellular matrix in between them. Compare that to spastic muscles, and you see that the extracellular matrix is more disorganized, loose, and hypercellular. And it turns out that this spastic extracellular matrix gives an abnormal ultrasound image. So we actually can see this when it develops. So what are if I was going to summarize quickly, the chronic transformations of muscle in spasticity? Well, there's, as we said, increased extracellular matrix, connective tissue, and fat deposits, all leading to what we see clinically as clinical muscle fibrosis. There's abnormal gene expression that promotes tissue fibrosis. Muscle fiber size is more variable in spastic muscles and differs in the amount of type 1 and type 2 muscle fibers. And there is some viscoelastic properties of muscles that change. There's accumulation of hyaluron with an increase of fascial thickness and less muscular sliding, which is needed for good muscle physiology. And to the far right, you see a muscle histology, panel A, normal, panel B showing increased stain for hyaluron, and panel C is when they use an enzyme that debrides that, you see it goes away, showing that really that is increased hyaluron in panel B relative to the normal panel A. So what is the impact then of spastic muscle in humans? Well, we do a lot of treatment as podiatrists on this, and so we're a lot of times doing botulinum toxin injections, and these act to treat spasticity, and they act directly on the muscle. Well, histological changes in muscle, remember, that are occurring, these are happening that are distinct from the abnormal descending inhibition pathways that I showed in the earlier two slides. And these muscle changes could affect treatment outcomes with our injections, namely botulinum toxin injections, that target muscle. And it turns out that muscle fibrosis may be an unrecognized or not a highly recognized cause of why we see non-responsiveness to botulinum neurotoxin injections. That's abbreviated as BONT. So, how do we assess spastic muscle anatomy clinically? Well, ultrasound is a great, reliable method to do this. And as Trevor alluded, this has been an interest of mine probably since the early 2000s. So I've been doing this for quite a long time. And it's so nice to see how this has become relevant to the field here. But when we look at ultrasound, there's two ways that you can assess muscle. It could be sonolastography or echogenicity. Sonolastography provides information about muscle tissue stiffness. It measures tissue displacement to an application of the stress, and it's really the transducer that's being placed upon the muscle or the whatever you're happen to be studying. It does not show muscle echotexture, however. It's really more useful clinically to determine a cystic lesion from a solid tumor. So it's used clinically more in cancer type clinical scenarios. And for now, while you'll see an occasional paper, I believe there's limited value for now in spasticity disorders. Well, echogenicity, I think, is where the money's really at for this. And of course, we use BMO to determine this. Simply stated, tissues that are bright are highly reflective of sound waves. Tissues that are dark or hypoechoic have fewer sound waves reflected back to the transducer. If you look at muscle, it really is hypoechoic with just some hyperechoic or bright lines or dots throughout it. You see the bone has a bright line. Beneath the bone is black. That's cortical shadowing. The ultrasound beam can't get through the bone. And then fluid could be black as it's seen there. And I think most of you probably have had now some experience in ultrasound, and this is probably just review information for you. So how do we then assess echogenicity in spastic muscles? Well, remember, spasticity can alter both the histopathological and the sonoacoustic properties of muscle. As spastic muscles undergo atrophy and fibrofatty replacement of contractile elements, they may appear hyperechoic on ultrasound, or i.e. are bright. And this echo intensity can be assessed qualitatively or quantitatively. So back in the day, Heckmit and Dubowitz developed this scale actually in the 1980s or 90s, and it was designed exclusively for Duchenne muscular dystrophy. They're trying to look to see in the young boys how the muscles were changing. And so this has been around for a while. It is not validated for use in spasticity disorders. And the big thing is that in Duchenne, you see some of these pictures to your left here, the C's and D's. You see in myopathies, there is a diffuse change within the muscle. And sometimes it's really hard because of these diffuse changes in myopathy to see the changes relative to maybe the stage 3 or stage 4 grades. And so an interesting scale, but not quite useful enough for what we need in spasticity. So because of this, we developed a study that's gotten some legs. We've worked with our colleagues, Rajiv Ribai, University of British Columbia, Department of PM&R, and we've published this article in the Archives of Rehabilitation and Research and Clinical Translation, I think 2020. The reason we did this is because we knew that spastic muscle does not show the typical uniform pathology seen in myopathies. Instead, there are areas of hypoechoic, which is more normal appearing, and hyperechoic, bright abnormal signal that can be seen in spastic muscle. And these are not well classified by the original Heckmit scale. Our modified Heckmit scale was designed to obtain greater specificity between grades by documenting the percentage of increased muscle echogenicity. So I want to just briefly kind of run through the study for you because this will be an important thing as we move forward in the talk. So our design, this was a prospective observational across 2 academic centers, Vancouver and Pittsburgh. We had 40 total adult patients. 45 patients were actually diagnosed with upper and lower limb spasticity. We had 5 healthy references, control. We had 100 total images, and the images were de-identified and the reviewers were blinded. We had 2 residents and 2 experienced physicians, so 1 resident, 1 staff physician on each site. We all visually assessed 100 ultrasound images, had some training beforehand, then we went in with these definitions I'm going to show you in a second. And what I think was unique about the study is that we used a quantitative grayscale assessment using ImageSafe software. So this is a computer program that can, when you point an area of interest to the program, it gives you a relative brightness. And so that allows the modified Heckman scale to be compared to a quantitative computer analyzed grayscale to see how that relationship is or isn't. So our data really showed pretty good intra-rater and inter-rater reliability, and this was good to excellent within and between clinicians. Interestingly, we tried to look for subject-level characteristics that might predict the modified Heckman score, and we looked at things like age, BMI, MAS, duration of disease, duration of prior botulinum neurotoxin treatment. Nothing was significant. So really, this modified Heckman kind of stood on its own in terms of telling us something about the muscle that nothing else seemed to give us in terms of the covariates that we studied. Now, the important thing with the quantitative grayscale, you see on the y-axis, these are the grayscale numbers. Now, again, 125 versus 25, these numbers have no clinical meaning. They just are levels of intrinsic brightness of the image. And on the bottom are the modified Heckman scores. They go from 1 to 4. And as you see, 1 is on the normal side, 4 is on the abnormal side. And you see as we progress from normal to abnormal on the x-axis, we get a corresponding increase on the y-axis. And so that showed a very good, I think someone's bled through. I don't know if someone can mute your mic there. Somebody kind of bled through there. Thank you. There's a really good linear relationship between the two, which indicates that our clinician-graded modified Heckman scores that are done in real-time ultrasound with the patient appear to be equivalent to the quantitative grayscale. So it allows us to really use this scale in a lot of ways in the clinical realm confidently. So this is the modified Heckman scale, in case no one's seen this. So this is a modified Heckman 1, and we have defined this as normal echogenicity in greater than 90% of the muscle that is distinct from the bone echo. And here you see the FCR muscle, kind of a beautiful looking muscle here. So that's a normal looking grade 1. This is a pronator teres muscle, grade 2. And here, again, what's unique about our scale, we're giving percentages of abnormal. So here, 10 to 50% of the tissue has increased echogenicity. You kind of see a little bit here. Hopefully you can see my arrow and you see a little bit in here, but the outer rim of the muscle looks good. This is a modified Heckman stage 3 here, and here we define a grade 3 as between a marked increase between 50 to 90% of the tissue with reduced distinction of bone echo from muscle. And these are images from the gastroc muscle. And again, different than myopathy, not all the muscle shows it, but a great percentage of the muscle shows these hyperechoic changes. And then this is grade 4 image to the bottom right. Here is a very strong muscle echogenicity with near complete loss of distinct bone echo in greater than 90% of the available muscle tissue. So, can the modified Heckman scale be used in clinical practice to examine architectural changes? Of course it can. We use it every day in our clinics. And this is an example I'm showing to you. This is the same patient. On the right side is the unaffected arm. The left is a hemiparetic arm. And if we just look at the right arm for now, you see the PT, pronator teres, FCR muscles. There are modified Heckman 1, good normal appearing muscles. And now if we look on the other side, here you see hyperechoic streaking, fibrosis, and fatty infiltrate within these two muscles, muscle atrophy. And these are, the peroneal arteries is probably a modified Heckman 4, and the FCR probably a 3 transitioning to a 4. And so these muscles are clearly abnormal. And if you were going to inject them with botulinum toxin, you may wonder, is the toxin going to be as receptive as it would be, for example, if the muscles look like the normal side on the right side? And so, again, this is something we use and you can use every day in the clinical setting. So this led to our next study, which I want to talk to you about. This is a study that we just presented the data in the recent Spasticity X conference in Houston. Don't know if anybody here went to it. It was a phenomenal conference. Gerard Francisco sponsored an international conference from all walks and areas of individuals internationally who really enjoy this space. And so I want to share some of this data here. We're in the process of writing this up. Hopefully we'll get this submitted within a few weeks. That's the goal here. But this is a prospective observational evaluation of muscle echo intensity and EMG insertional activity in post-stroke spasticity. Again, Rajiv Ribai from University of British Columbia, myself, and Alessandro Picelli from University of Verona. These are the 3 sites for the study. So the rationale is as follows. We wanted to know what was the significance of increased muscle echo intensity on muscle conductivity, because it's really unclear up till now in patients with spasticity. It is unknown whether the muscle electrical activity changes with differences in echo intensity as measured by the MHS, is my abbreviation for the modified Heckman scale. Our primary objective is to determine if a correlation exists between spastic muscle echo intensity and EMG insertional activity as a biomarker of muscle health. Reduced or absent EMG insertional activity is consistent with fibrofatty infiltration, and increased insertional activity is consistent with denervation. So we wanted to see, are these things relevant to what we're seeing with the changes in echo intensity? So again, just to highlight this study, the methods, a cross-sectional, observational, prospective, 3-center study, one academic American, one Canadian, one European center, all PM&R centers. Inclusion criteria, age greater than 18 years old. They had to have ischemic or hemorrhagic stroke with associated spasticity affecting the upper and or lower extremity. We had 55 patients from all the centers with post-stroke spasticity. And these were patients who were either getting botulinum neurotoxin injections for muscle spasticity, or they were being considered for treatment. So they all had spasticity, some being treated, some being considered for treatment. Now, these were how we defined our definition for EMG insertional activity. No electrical activity, which is really what you see in pure muscle fibrosis, was absent muscle fiber potentials after the needle is quickly moved without muscle sounds to the speaker. A reduced insertional activity is decreased in brief burst of electrical activity when the needle is advanced. And hopefully for those of you who do EMG, this makes sense. Muscle with muted sounds to the speaker. Normal activity is what you normally see when you move an EMG needle through muscle. And increased insertional activity were fibrillation and positive wave potentials that persisted greater than 300 milliseconds. So all 3 sites assessed EMG insertional activity in muscles that were graded modified Heckman 3 and 4. And again, these were the muscles with the most significant changes. Only my site assessed the EMG insertional activity in muscles graded 1 or 2, the least significant changes. And this has allowed more balanced numbers between the 2 groups. So these were the muscles that we looked at for all the patients who were studied: the biceps brachialis, FCR, peroneal arteries, rectus femoris, medial gastroc, lateral gastroc, and soleus. And what I'm showing you here to the right, we had standardized positioning for where we put the ultrasound transducer. So we tried to standardize ultrasound settings and the positioning of where the muscles were imaged to be as uniform as we could across sites. So what did our data show us? So on the x-axis here, you see the two groups, MHS1 and 2, MHS3 and 4 on the y-axis, abnormal electrical activity. So everything that I showed you that was abnormal collapsed into one group, or everything that was normal. Let's start with the MHS1 and 2 groups. You see, just as we would have expected, that almost 92% of them had normal electrical activity. So that's really excellent to know that when we see a normal appearing muscle, for the most part, 92% of the time, it's normal electrically as well. Now, 8% is abnormal, but the vast majority, which I'm going to show you in the next slide, is denervation, which we believe are the lasting effects of botulinum toxin. Now, let's compare that to the MHS 3 and 4 group. And here, this is kind of what we're hoping to see. In muscles that have abnormal echogenicity, they appear abnormal, like I showed you in the protein arteries and FCR slide a few slides ago, 54% of them had abnormal electrical activity. Interestingly to me, a good percentage, 46%, had normal activity. So I thought this would have been a little bit lower, frankly, and we'll give you some reasons why we think this could be. But these differences were highly statistically significant. Now, this slide breaks down the types of abnormal insertion activity correlated to the modified Heckman scale. So as I was alluding to, in the MHS 1 and 2 group, the vast majority of abnormalities were fibrillation of positive waves. And so, as you know, when you inject botulinum toxin, that's a chemical denervation, and you can see fibrillation of positive waves. So I think that's what we were seeing. Only 2% of this abnormal group, which really represents maybe, two out of 12 subjects, which represents about 1 to 2% of the entire MHS 1 and 2 group, had reduced insertional activity. So really a vast minority. When we look at the 3 and 4 groups, again, the majority had either reduced or no insertional activity. So this is fibrotic muscle. Now, there was a portion that had denervation, but these fibrillations qualitatively looked different. They were smaller. And I think this is actually chronically denervated muscle that's in its transition, I believe, to fibrosis. And these differences were statistically significant as well. Okay, so I'll just quickly kind of summarize what it is that we had found with this most recent study. So the MHS and EMG insertion activity combined really can act as biomarkers of spastic muscle integrity. And it almost approximates what you can learn from a muscle biopsy. And of course, we can't muscle biopsy our patients, but we're getting really great clinical information at the bedside this way. 54% of the MHS 3 and 4 muscles had abnormal EMG insertion activity consistent with fibrosis or fibrofatty infiltration. Some had chronic denervation, like I said, that reflects this transition to abnormal muscle physiology. However, a good percentage of these patients, these muscles, had normal EMG insertion activity. So why could that be? Well, remember I told you earlier there's that increased extracellular matrix that is bright. I showed you the slides by Lieber. And I think that's what we're seeing here, where the muscle fibers have not yet changed, but the extracellular matrix is what we're picking up. There's also other studies, which I'm not going to show you here. There can be thickening of the perimysium, the connective tissue cover of the muscle fiber bundles, and that's highly reflective. So perhaps that's why we're seeing in these MHS 3 and 4s bright signal, but not yet conversion. But I do believe that these muscles are probably at risk, but maybe not there yet for going into full fibrosis. Except for time since stroke, no specific factor was identified to explain the rate of increased echo intensity and transition to fibrotic tissue. I didn't show you this data. I'm just summarizing this for you. And we did look, I didn't show you this, but just to tell you, we looked at the neurotoxin mean dose. It was slightly higher in the MHS 3 and 4 versus 1 and 2, about 10 units higher per muscle. We're not quite sure if that 10 units per muscle average dose makes a huge difference, though. So, it wasn't statistically different, and so we're not quite sure what to make of that. Our findings do suggest a multifactorial process influenced by genetic and epigenetic variables that appears to be specific to each muscle within each patient, because it turns out certain muscles like the gastroc, medial lateral gastroc, and protein arteries are much more likely to show changes than, let's say, the FDS, the flexure digitorum superficialis. So you might be asking, this is all well and good, but what are the clinical applications of using the MHS during chemodenervation procedures? Again, this is a lot of what we do in spasticity clinic. Does this have a role? And my answer is a huge, strong yes. And I'm going to try to give you some reasoning now in the next few slides why that might be. Well, our data certainly suggests that if you have ultrasound and EMG, you should monitor this, because if you see reduced insertional activity and/or I would say either MHS grade 3 or 4 muscles, you may want to think about how you're dosing your botulinum neurotoxin. Also, remember I told you that in some of these muscles, it's not like a myopathy, there's not a diffuse change in the muscle, there's pockets of change, pockets of muscle that maybe aren't changed, excuse me. So you want to then target your neurotoxin to the hypoechoic pockets in these MHS grade 3 muscles that may represent viable muscle targets that could be influenced by the medication. And if muscles really show MHS 3 or 4, you may consider not injecting them with botulinum neurotoxin, instead using them in MHS 1 and 2 muscles. We do this all the time. I told you that the gastrocs appear to be particularly prone to this change. So a lot of times we have stopped injecting the medial lateral gastroc and are just injecting soleus, because we see all these changes, and it's allowed, I believe, us to maintain good treatment in our patients with equinovarus or Aquinas type spastic deformity. And you could also consider surgical interventions. If you're seeing all these muscle changes, perhaps you don't want to waste your time and the patient's time with botulinum toxin injections. Maybe consider surgical interventions that could be better when the muscles are looking this way. So what's another clinical use of the modified Heckman scale? Well, this paper just came out this year in the journal PM&R. This is by Kristen Harris. I'll just briefly present her work. She studied leak of injectate in neurotoxin injections into the flexor carpi radialis, and they recorded them on ultrasound video. Remembering that whether you do blind or EMG or e-stim or whatever guided, or even ultrasound guided for that matter, even though you're injecting, you think into the muscle you think it is, it doesn't mean the injectate stays there. It's amazing how the injectate spreads. And what she was trying to see is, are there any factors that may influence the spread of toxin? It doesn't always stay where you think it's going to stay. And she looked at 54 patients. Injectate leak, for the leak of the toxin through. And remember also the fascia around the muscle. These are not watertight fascia. It's easy for the injectate to potentially leak out. She found almost a 20% rate of injectate leak, and her multivariate analysis demonstrated an increased odds of leak with higher modified Heckman score, 3 or 4, had a significantly higher rate of leakage. What I think is even more fascinating is that there was no statistically significant increase in leak with higher volumes, usually it's like a 2-to-1 or 3-to-1 dilution of the toxin, or in smaller muscles. So those would have been kind of what I would have thought beforehand, but no, it's perhaps the stiffness of the muscle as indicated by the fibrotic change as determined by the modified Heckman scale that seems to be what's imparting a leakage of neurotoxin. So really great work by Kristen Harris and her group. Now, is spastic muscle echo intensity potentially related to outcomes? Well, there's one good study by Pacelli that was published in 2012. Small study of 21 post-stroke patients with spastic equinus injected with botulinum neurotoxin. He documented a statistically greater improvement in range of motion in the, now he used the original Heckman, not the modified Heckman. And so, the grades aren't quite as good, but he saw that the grades 2 had better range of motion than grades 3 or 4. Used some older technology as well. So this study is really interesting, probably needs to be replicated in a larger sample using the modified Heckman scale, probably using more modern ultrasound technology. You can kind of see the images on the left of the screen. um, not as clean and crisp as current technology would show. So ultrasound guidance then is great for assessing the modified Hetman scale. Hopefully, I've convinced you of that. But I'll just end up with a couple of slides here. How can we use ultrasound of muscles to improve localization with botulinum toxin? And let's see, hopefully this plays here. So this is a botulinum injection, neurotox injection to FDS belly 4. And let's say stop there. So this triangular area here, that is the injectate here. Just to show you the anatomy real quickly for those unfamiliar, this is the flexor carpi ulnaris here. This is the ulnar artery here, ulnar nerve, flexor digitorum profundus here. This is the FDS, but the FDS has various bellies, and this is the FDS belly 4. Hopefully you can see my pointer here. I'll play this video one more time just to see it again here. So here's coming down an out-of-plane injection, and you see the triangular hypoalcoholic or dark fluid, which is the neurotoxin injection. And so this is about maybe 1 centimeter deep of injection that we're putting here under the skin. Again, the one thing that ultrasound tells you is that you're without visualization, you're probably injecting way too deep. For most of us, we're using either 38 or most of the time 50 millimeter monopolar injectable needles if we do an EMG guided perhaps injection. Well, this depth, 2 centimeters, this is about 1 centimeter right here. 2 centimeters is here. So on a 3.8 centimeter, the smaller of the two needles, if half your needle is exposed, you're going to be down in the FDP, and you're going to be missing the injection here in the FDS. And without ultrasound, you're not going to be able to really see the various bellies. So just a good little slide to show you how relevant ultrasound guidance is to making targeted, accurate chemodenervation injections. And hopefully you're perhaps doing some of that at your local facilities. If not, there's great ways to learn in our national meetings. We're usually trying to teach and show some of these techniques for those interested in wanting to learn. So ultrasound in chemodenervation procedures is also helpful to avoid major vessels and nerves. So here I'm showing the flexor digitorum longus, this muscle outlined in blue here, and you see the so-called Mickey Mouse, and that's the big one is the tibial artery, and the two other ones are the tibial veins, and you see that the tibia bone is there. So if you're just a little bit off, you're going to be puncturing these neurovascular structures. Here they're shown over here, different image here on the right of the screen, and the purple arrow here represents the needle path that you'd want to use to successfully inject the flexor digitorum longus and avoid puncturing these structures. The other thing I'll say about the utility of ultrasound guidance, just two other quick points for those perhaps who aren't as familiar. We see our patients 3 to 4 times a year, and if we can do our injections in a way that causes less pain, that is going to improve their ability to want to come see us on a regular basis and not drop out. The dropout rate with neurotoxin injections the first year is actually quite high. It's almost up to 40 to 50% in some studies. And I think a part of that it could be explained by just the discomfort. So if you see structures that can be painful if you inject them, to avoid them really helps to build good compliance with therapy. And so I think that sometimes is not talked about as much as it should be. The other thing that's not talked about as much is just consistency. Especially, we do a lot of cervical dystonia injections. It's not a point of the talk now, but just as an example, the muscles like splenius capitis, semispinalis capitis, oblique capitis inferioris, they're on layers on top of each other. And oftentimes, if you're just doing perhaps EMG, you get some benefit, but there's not when we say splenius capitis, we really are in the splenius capitis. And so assuming that we've done a good job diagnosing what muscles are moving the head in terms of the dystonic posture, we can ensure a very consistent outcome cycle after cycle. And again, that leads to better compliance. So these are some unrecognized gains of why ultrasound guidance, I believe, has a really, really important role in our chemodenervation procedures. Okay, and I think I'm going to finish up with this here. So this is a study that just came out, I think, last week. This is by I'm not part of this group. Alberto Esquenazi and the Abolish researchers did a longitudinal goal attainment study with repeat cycles of injections in patients with lower limb spasticity, a prospective observational study. And they did a multivariate analysis, and their primary outcome was goal attainment scale. And this is a validated tool where you look at a goal, and it's kind of a 5-point scale. Kind of -2 is with an anchor is way below the target goal. -1 is below the goal, is below the current status. 0 is current status. 1 is above the goal. 2 is way above the goal, and there's anchors for this. And you can read about the goal attainment scale. It's validated in spasticity and well used. So they use that to determine their efficacy of neurotoxin in lower limb spasticity. But what I'm getting at here is that their multivariate analysis indicated that the lower limb goal attainment during the first injection cycle was statistically better using guidance. And in this case, it could be ultrasound, EMG, or E-stim, or most often a combination of those three, compared to those without guidance. So for those of you doing chemodenervation, ultrasound and EMG are your friends. So let's kind of summarize, and I'm happy to open this up and take questions and make this more interactive. Again, it's one of the negatives with a Teams call, but hopefully this has been helpful. But let's kind of summarize some of the take-home points. I've shown you that muscle architecture can change in spasticity disorders. Spastic muscles can have an increased echo intensity on ultrasound due to fatty infiltration and/or fibrosis. Muscle echo intensity can be quantitated or quantified using the modified Heckman scale. The MHS can potentially optimize muscle sites for chemodenervation. And spastic muscles with increased echo intensity and decreased insertion activity are likely going to respond less favorably to botulinum toxin. And so you can use this information clinically in real time to optimize your outcome with these patients. So this is the Point of Pittsburgh. If you're ever there, take a look. It's a great place to visit. And at this point, I'm happy to open it up. And Trevor, I'll let you kind of run this show at this point and take any questions that you have. Thanks so much for listening to the talk. Yeah.
No questions in the chat yet, but I'll lead off with a question. I was really interested, and I thank you for sharing all that with us. That was really great. I was really interested in the idea of the leakage of the neurotoxin from the muscles that you intended to have it in. I wondered if you might have answered this already, but I just wanted to clarify. Is it clear whether the efficacy of the neurotoxin is decreased specifically by the leakage of the neurotoxin out of the intended muscle, or if it's because the neurotoxin is in the intended muscle, but it's less effective because of the changed architecture of the muscle, or is it a little bit of both? Can you shed some light on that?
Right. So I don't believe in Kristen's study that they looked necessarily at outcome. They were looking just at leak. But to answer your question, if the muscle is not internalizing the toxin, you're not going to get that specific effect in the muscle. We see this all the time. I don't know. Does anybody do phenol injections besides David? But in phenol, how many times, back in the day, would you do it? You think you were right on top of, and you get a little bit of a benefit, and all of a sudden, in a week or so, the benefit goes away. And you're like, damn it, I thought I did a really good phenol block. Well, when you look at ultrasound, you get this effect, and the phenol bounces off the nerve and layers most away from the nerve. And so that explains why your phenol, even though you think you've injected it at a low milliamperage of current, didn't stay where you wanted to. And now, we're using ultrasound in our phenol injections and we're hydrodissecting to make sure that the phenol stays where we want it to stay. But with chemo if it leaks out of that muscle, it is not going to internalize and get into that muscle where you want that specific muscle effect to happen. So hopefully I've answered that question here. Let's see here.
Yeah. I've got a few questions in the chat.
Sure.
Do you still use EMG guidance in any cases?
Yes. So, great question. So, ultrasound, here's where I don't use ultrasound. I have some patients with adults with CP that have kind of a ballistic type of a tone, kind of, when they're flailing their limb, or they have so much spasticity, they just tremendous spasms, or patients with low tolerance with the procedure. You got to be quick. In all of those cases where you got to be quick and it's just not the ability to kind of sit and analyze the muscle, EMG is my friend for that. And I don't use ultrasound in those cases.
Gotcha. Thank you. Another question. Have you seen any further literature on hyaluronidase injections? It's available through the VA, but Dr. Caruso says she's had trouble getting approved for use of it without further research.
Yeah, so I would say don't use it clinically because there's no efficacy that it works. What I showed you was more the research. Prithi Ragathon is doing all the work on this area, so I would have you read her work. But at this point, I don't believe. I think she's starting some clinical trials. So until we see some of her clinical trial data, I don't think there's evidence-based to use that at this point.
Right. I've got one other in the chat. So one of our esteemed pain fellows, Zeev, wants to know, is there a risk that insurance companies would use this or similar data to rule that patients with advanced spasticity with changes in MHS score 3 to 4 may be denied coverage for botulinum toxin as benefit may be reduced?
No. No. I can't, I can't see that. They're not smart enough or they don't care enough, I don't think, to necessarily know that.
If they do figure it out, we might be in trouble.
Right. But I would say, but again, I think, the more important point is that when you're treating your patients, you should be looking at this as a potential cause of why patients aren't responding with botulinum neurotoxin the way you expect them to be. And if you see this, you should be, and I do this all the time, real time changing my protocol when I see muscles that are starting to change. And I'll tell patients, you know what, we're just not going to inject your gastroc muscles anymore. We'll do the soleus, maybe we'll do the tib posterior, the varus component of your, and if you really want, we can't do rehab things, maybe we look at a surgical Achilles tendon lengthening in that case. So again, I think that's the more important take home message in my mind.
Okay. I did think it was interesting when you were talking about, maybe the gastrocs are not amenable to the neurotoxin injection anymore. So you do the soleus instead as an example. And you find that pretty readily overrides the gastrocs if they, get fibrosed or,
I think it allows you to get some bang for your buck with the neurotoxin. I think if you inject those patients with neurotoxin in the gastroc muscles that have MHS 3s and 4s, you're not getting it. You're not doing anything for the patient. So yes, we absolutely think that we're getting at least some decent benefit that way, and it's a better I think cost economic use of an expensive drug medication.
Any other questions online? Dr. Gordon would like to know, is there any evidence that using botulinum toxin accelerates fibrosis?
Oh, great question. Great question. So, that's why I showed you that at one point that there was a little higher mean dose in the MHS 3 and 4 with our EMG study. But in our data, I don't think that's going to show to be a huge deal. We do know there's some studies like by Valentine, I don't know how he did this, in kids who got injected in 2016 study, and they actually did some muscle biopsy and showed some changes from type 1 to type 2 in more frequently injected muscles. And so there might be some change, but I don't think our data would say that toxin is the only reason. I think it's inherent to the underlying pathophysiology of the process. It is not a drug only, because we do look at some patients who have chronic spasticity and never got injections, and they show these changes as well.
All right, thank you.
Hey, Mike, I want to just reinforce what I said earlier, but you're the best at this, man. That was fantastic.
Thank you,
Really
David.
is. I learned a lot of things, and I like to dig about the phenol, but other than that, it was wonderful, man. Really appreciate everything you're doing for the field too, Mike. It's really fantastic.
David,
And we're privileged to have you spend time with us. Thank you, buddy.
Well, David, it really means a lot. Thanks so much for those kind words, and have a great day, everybody. And we'll see you soon.
Thank you.
All right, take care. Bye now.